epithelium present, you describe it as closed. Because once you've had a pressure ulcer, you're already at increased risk of developing it in that same spot again. Okay, you must be able to stage pressure ulcers. I think this information is new, so pay close attention. Stage 1 is essentially a closed pressure ulcer. The skin is intact, but it's a different color than the surrounding area. The skin may also be a different temperature. It will be thicker. And if they have sensation, it'll be tender. Or they might not have sensation, then it would be diminished. That is stage 1. Stage 2 is partial thickness. Or it might be a closed blister. So if it's blistered, or if it's open but shallow, partial thickness, then it's stage 2. Stage 3 is full thickness, all the way through the epidermis and the dermis, with potential for exposure of subcutaneous fat. But if any other tissue, such as bone, tendon, or muscle, is exposed, then it is now a stage 4. So stage 3 and 4 are both full thickness. Stage 3 is subcutaneous fat exposure only. Stage 4 is bone, muscle, tendon, ligament, any other tissue exposed is stage 4.
Have you ever seen one that bad?
No.
You have to be in one position for like a really long time.
Do you want to tell us about the patient?
I just asked about it.
It's a dry guy.
It wasn't even like.
Not the right way.
I'm trying to see what it was.
Patient modesty.
Yeah, patient modesty was not there.
Oh, can you describe, like, maybe, like who was someone that ended up with that?
Yeah, this was
Okay, everyone look it up.
the elderly female in her 80s. She's nonverbal. I think she had a, I don't know if she was also in a stroke, but she was basically catatonic, contracted, and was in a care facility, and sacral DQ, and you could actually see from the structures of the pelvis. She also had full thickness wounds on both bilateral heels as well, and she's just contracted. She's really,
Yeah.
so DNRs, people, DNRs.
Okay, so again, #1 treatment is what?
Prevention.
Prevention.
One alone is
After
me.
that, we need to do patient and caregiver education. You definitely have to relieve pressure. They actually have dressings, like foam dressings, that will help pad the area. Foam dressings are also useful if there's a lot of exudate. The moisture status of the wound and make sure the peri-wound doesn't degrade. But #1 is the pressure needs to be relieved. If it's not, the wound will just continue to worsen. Okay, you should be able to recreate this chart from memory by your 3rd exam. What slide number is this? 20. I'm gonna write that down. Slide number 20. Pay close attention. Okay, so venous, arterial, and lymphatic ulcers all look very different from each other. Okay, so we'll talk about venous ulcers first. They can be located anywhere from the ankle to the mid-calf, but the most common area they end up showing is on the just superior to the medial malleolus. So there's a wound just superior to the medial malleolus. There's a very high likelihood it is a venous ulcer. Their borders are irregular. They are in a regular shape. The wounds tend to be shallow and very wet. They have a lot of exudate. They're mild to moderately painful. Again, the pain with venous insufficiency is relieved with positioning, elevation. Pedal pulses will be normal because it's not an arterial issue. But they are going to have a whole bunch of edema. Skin temperature may be normal, it may be a little overheated. What else are we going to see in the skin surrounding the venous ulcer? What color is going to be the skin around the ulcer? Well, we may see varicose or tortuous veins. Darker, what do we call that? Hemosiderin stains. Dead red blood cells. Hemosiderin stains. Okay, so as we just went through, the wounds happen because of venous insufficiency, which means there's incompetent valves, and you have to promote the muscle pump. Lots of edema, lots of fatigue and achiness, and we have hemosiderin stains. Remember, we have the lipodermatosclerosis, which is the thickening of the skin. And telangiectasia is the tortuous veins. You see the veins popping out, and they are like rising in all directions. Okay, so you already know how to treat patients with venous insufficiency. These wounds tend to have a lot of exudate, so how are you going to treat them?
Suck it out.
You're going to remove the exudate, or use a dressing that is very absorptive. I want to absorb the exudate.
Absorbent. Absorptive.
Absorb it and absorb it. Both work.
Diaper commercial.
If we had that up.
Aluminium.
Yeah.
Aluminium.
Dry out.
Put a bunch of
So there are some cases where maybe you want to leave it exposed temporarily to help it dry out, but you don't want it to dry out too much, and keeping it exposed means bacteria can get in, or it won't be protected from exercise. So that's why you're going to use a dressing. We'll talk about that more when we discuss dressing to talk about the exit.
The answer to your question is no.
It's awesome. Okay, arterial ulcers.
Not real.
Probably like vitamin B.
Even if possible.
Yeah, it's just a bunch of vitamins.
I'm on it right now.
Then it's definitely not
I'm in
working.
the zone.
Okay, arterial
Death
wounds look very, very different from venous ones. They can appear anywhere in the lower 1/3 of the leg. They are most common in the dorsum and the distal toes. They have very smooth, well-defined edges. It'll be very obvious where the wound starts and ends, unlike venous ones. They tend to go very deep. They are painful. Pulses will be diminished or absent. Dependent Ruber test will be positive. And remember, the skin around it is thin, shiny, with hair loss. and nails may be yellowed. They also tend to have a lot of eschar, so they are very dry. You don't want the eschar to be too dry, but remember we're not removing the eschar because there's not enough circulation, therefore new tissue cannot regenerate until circulation is restored. Okay, we already know that.
If you use aloe vera, it won't escar.
Okay, lymphatic ulcers. They can be anywhere in the arms and the legs. They're only going to be in the presence of uncontrolled lymphedema. They're most common at the ankle/mid-calf region. They also are very shallow and kind of more widespread. Like you'll see a whole bunch of little ulcers in one area. They are very, very, very wet. They will be oozing. And you'll see lymphedema in the skin around it. The skin is very firm, taut, fibrotic. And they are at a high risk of developing cellulitis, which is an infection and will make the wound ooze even more. Actually, anyone who's older and has diminished sensation is at increased risk of getting cellulitis because it's just bacteria. You can just have a little break in the skin, piece of bacteria gets in, and then the skin becomes very red and inflamed and oozes. Yes, Mike.
With the venous ulcers, would the edema not cause problems with the pedal pulse? Like just if it's in the area, swollen tissue?
I mean, it might be harder for you to access it, but they would still be normal because the arteries are the same.
Okay.
Yeah.
Thank you.
Okay, so lymphatic ulcers, you have to reduce the lymphedema and prevent trauma to any area that does have lymphedema. Because there's large amount of moisture, again, we have to use a dressing that will absorb that moisture. And again, treat the lymphedema.
No, that would be really
But it wasn't like warm, right? It was just like it was probably infected in there. So one of interesting patient I treated on my wound care rotation. So they had cellulitis, and they had some sort of surgery, and then they got cellulitis. It basically, in their entire, from the knee down, was red and swollen. So the doctor came in to drain the knee, because the knee, especially that area, had a whole bunch of swelling in it, and he literally just slit it open right here and squeezed stuff out of it.
Sweet.
Yeah. It's horrible. Yeah. And so they just squeezed all this swollen, infectious, purulent exudate out of the patient.
Yes.
And then stapled her back up again. No, that part of the knee part, they just squeezed the fluid out of it. She actually had the secondary open wound on her ankle that required packing. It's real hard. Okay, this is the other really important slide. What slide number is this? 28. So 20 and 28. You should be able to recreate those charts from memory. Okay, so this chart goes over the treatment goals, what therapies and procedures are going to be performed, and specifically what the wound care will look like. Okay, you already know the goals and therapy procedures because we went over peripheral vascular diseases. Okay, so venous wound care. You need a dressing that will absorb the exudate. Same with lymphatic. And especially with lymphatic, you need a dressing that can manage large amounts of exudate. It's going to be what's called alginate, but that will get you another day.
Chamois cloth.
Wow.
Arterial wounds, you keep the wound dry and protected. Don't remove the eschar.
That's two, Ron, you got it right now. What, the ShamWow for the lymphedema drain?
Okay, we're going to call it a day. Let me know if you have questions about tomorrow's exam. Practical.
Thank you so much. Yes, ma'am. Thanks for the power.
Thank you, Mom. You're welcome.
The slaughterhouse?